Dear colleagues, I would like to thank the organizers as well as the company of Ferring to give me the opportunity to discuss the evidence regarding the use of Follitropin delta in the IVF clinic and to share our experience with this gonadotropin in our center in Brussels. In this presentation, I would like to discuss the available data regarding an individualized approach to ovarian stimulation with a recombinant gonadotropin derived from a human cell line using an algorithm based on AMH and body weight. I will discuss how we can achieve targeted ovarian response, and by doing so, how we reach an optimal balance between safety and efficiency of an ART cycle. So we can distinguish different ovarian response categories. According to ESHRE consensus, poor ovarian response has been defined as the retrieval of less than 4 oocytes following a standard IVF protocol. And the term hyper-response refers to the retrieval of more than 15 or more than 20 oocytes following a standard ovarian stimulation protocol. Women with poor response have a low live birth rate per cycle, and hyper-response confers more side effects. Now, a higher oocyte yield may reflect adequate ovarian reserve and a good response to ovarian stimulation rather than the stimulation protocol or the dose used. And this is often ignored because an observed relationship between a high oocyte yield and favorable IVF outcomes is often used as an argument to stimulate hard. But this is not the right thing to do. High response represents good prognosis patients, but there is no evidence from prospective studies indicating that a dose increase will actually improve IVF success rates. The only thing that goes up substantially beyond a certain point is the incidence of side effects, including OHSS. In a prospective dose-response trial in 265 women of less than 38 years, incremental doses of human recombinant FSH, Follitropin delta, resulted in more oocytes, but not in more good quality blastocysts. So the hypothesis is that only a limited proportion of the oocytes per egg retrieval have the potential to develop into a competent blastocyst. Nevertheless, in that study, and as expected, predicted hyperresponders had more blastocysts and a better cumulative live birth rate than predicted low responders. So you may argue that hyperresponse should be the target in women with a good functional ovarian reserve, and hyperresponse is no longer a problem because of the option of a freeze-all strategy. However, there are some pros and cons, some advantages and disadvantages of hyperresponse. Indeed, severe OHSS can be avoided if ovulation is triggered using a GnRH agonist followed by a freeze-all approach. And in women with an increased functional ovarian reserve, hyperresponse results in more usable embryos and increased cumulative live birth rate. But on the other hand, hyperresponse is not without risk. There is a risk of ovarian torsion, mild or moderate OHSS, thrombosis, and also in the freeze-all approach, you need to have an efficient vitrification and warming system in the lab. The time to pregnancy may be increased if no fresh transfer is performed. The question is also, what do you do with all these redundant embryos? So there is an ethical component, and frozen transfer in an artificial cycle is also associated with higher risk of hypertensive disorders in pregnancy. So what if we reduce the FSH dose in predicted hyperresponders? Then let's have a look at a milestone randomized controlled trial conducted in the Netherlands between 2011 and 2014 in more than 500 women with a predicted high response. It was the Optimist trial. Patients were randomized between a low dose of 100 units per day of FSH and the standard dose of 150 units per day recombinant FSH. Patients who had received a lower dose had fewer oocytes, on average 9 oocytes, but there was no difference in ongoing pregnancy rates per started cycle. However, the low dose group had a higher risk of cycle cancellation and poor response. So that's a problem. So the idea is to define a target ovarian response and to develop a model for targeted ovarian response after stimulation with human recombinant FSH. And the human cell line was chosen to resemble the glycosylation profile of native human FSH. So it's a novel molecule that resembles native human FSH. Because the translation of biological activity in terms of international units from an animal assay to humans is not the same for recombinant human FSH and animal-derived FSH, but dose-response categorization was needed in patients undergoing ovarian stimulation for IVF-ICSI. So Follitropin delta is a recombinant follicle-stimulating hormone uniquely expressed in human fetal retinal cell line. The human cell line was chosen to resemble the glycosylation profile of native human FSH, and Follitropin delta had lower clearance and higher ovarian response in humans than existing recombinant FSH preparations when administered at equal doses of biological activity. So how do we target ovarian response with this novel molecule? We have to consider the variables that modulate ovarian response. And according to the available data, the most important ones are anti-Mullerian hormone, the dose of follicle-stimulating hormone, and body weight. So to predict ovarian response, we have to consider the population of recruitable follicles, follicles that express FSH receptors and that can respond to FSH. And the size of the functional ovarian reserve can be quantified using biomarkers, including AMH. And AMH plays a crucial role in the pathogenesis of PCOS. AMH inhibits the recruitment of primordial follicles and promotes the survival of growing follicles because of its anti-apoptotic effect on granulosa cells. AMH also decreases FSH receptor expression and aromatase expression. So it makes AMH a key player in the control of follicular development. And in women with PCOS and women with high AMH, the dose response curve may be narrower. So this is a point of interest in predicted hyper-responders. In predicted hyper-responders, the goal is to avoid hyper-response because of all the side effects, but also to avoid hypo-response. So the dose response curve being narrow is more difficult to manage. And in predicted low responders, the goal is just to have more oocytes, and their maximal starting dose of Follitropin delta is possible to achieve maximum response irrespective of the body weight. But in predicted hyper-responders, the titration of the starting dose is in accordance to body weight and anti-Mullerian hormone. So the algorithm based on AMH and body weight for Follitropin delta dose was prospectively validated in a large phase 3 confirmatory study in more than 1,300 women, the ESTHER-1 study. This schematic depicts the treatment schedule used in this study. So women were randomized to either individualized Follitropin delta dosing, where with a fixed daily subcutaneous dose determined by the serum AMH level and the body weight. And then in the other group, women were assigned to conventional Follitropin alpha dosing with a standard dose of 150 units per day for the first 5 days, after which the dose could be adjusted. Now, the co-primary endpoints were ongoing pregnancy rate and ongoing implantation rates. The non-inferiority limit for the difference between these two groups was pre-specified as -8%. And as you can see here, Follitropin delta was non-inferior compared to Follitropin alpha with respect to ongoing pregnancy rate and ongoing implantation rate. There was also no difference between individualized Follitropin delta and conventional Follitropin alpha in terms of the secondary pregnancy endpoints, which were live birth rates, live neonatal rates at 4 weeks after birth, birth weight, and gestational age for live-born neonates. However, the proportion of women achieving the targeted ovarian response of between 8 and 14 oocytes was a predefined secondary endpoint in this study, and we can observe a better proportion of women, a higher proportion of women that were within this target oocyte yield. 13% more women in the Follitropin delta group had between 8 and 14 oocytes retrieved, which was significantly more than the women who were administered Follitropin alpha. Now, in both arms, 2 good quality blastocysts were obtained on average. So we could observe a better result in terms of obtaining the targeted ovarian response of between 8 and 14 oocytes, and also fewer women had low response after Follitropin delta. Only 12% of women compared to 18% in the Follitropin alpha group. And also fewer women had excessive response after Follitropin delta compared to Follitropin alpha. So based on this study, we could conclude that this algorithm was really effective in trying to have targeted ovarian response. This graph illustrates the risk of requiring preventative measures to avoid OHSS, including GnRH agonist triggering, frisol, and the administration of dopamine agonists. And with increasing AMH levels, the difference between the 2 groups also increased. So with women with high AMH levels had significantly fewer preventative measures to avoid OHSS compared to the Follitropin alpha group. Now, the ESTHER-2 trial was a follow-up trial after the ESTHER-1 trial, and there were 2 main differences between the ESTHER-1 and the ESTHER-2 studies. The dose regimen in the ESTHER-2 study was determined based on the ovarian response in the first cycle. So the algorithm was adjusted according to the oocyte yield in the first cycle. So there was a possibility to increase or to reduce the Follitropin delta dose in the ESTHER-2 trial. Now, what can we see in this ESTHER-2 trial? The cumulative rates after 3 subsequent cycles with either Follitropin delta or Follitropin alpha. And here in this graph, you can see the outcome. So there was no difference in cumulative outcome, which is the cumulative take-home baby rate was around 60% in both groups. Also really important to note is that repeated treatment with Follitropin delta in women who had pre-existing anti-FSH antibodies did not increase the titer of anti-FSH antibodies. So this repeated treatment in repeated cycles was not associated with decreased ovarian response and did not induce immune-related adverse events. Now, the cumulative incidence of hyperresponse was significantly lower in women in the highest AMH quartile who were treated with Follitropin delta. So the higher the AMH, the stronger the benefit of stimulation with Follitropin delta as compared to Follitropin alpha. So this makes this drug extremely suitable as a #1 choice for women with predicted hyperresponse, including women with PCOS. Now, to test the safety and efficacy of Follitropin delta in other ethnic groups, an RCT in more than 1,000 women was conducted in Asia. And again, Follitropin delta was non-inferior compared to Follitropin alpha in terms of ongoing pregnancy rates, which was the primary endpoint. Women with Follitropin delta had even a significantly higher live birth rate, although the study was not designed to assess this outcome parameter. So this trial confirmed that even though a higher oocyte yield was obtained with Follitropin alpha, so 12.4x after Follitropin alpha compared to 10x after Follitropin delta, this difference in oocyte yield was not associated with a better outcome in fresh cycles. And so this study also found that the higher gonadotropin consumption with conventional Follitropin alpha approach resulted in a higher occurrence also of progesterone rise. And this was previously found to be associated with inferior chances of pregnancy. So a better safety profile, although safety was only a secondary outcome also in this Asian study, the GRAPE study, less OHSS with Follitropin delta, and the higher the AMH, the better the benefit of Follitropin delta. Now let's have a look at our own experience with Follitropin delta in Brussels. The Follitropin delta dosing algorithm that has been predefined allows clinicians to precisely and easily calculate a patient's individualized daily dose of Follitropin delta for the first cycle. So we use Follitropin delta for IVF naive patients, women who have never had IVF. It's easy because you can use the functional ovarian reserve biomarker AMH and the body weight of the patient to figure out which would be the best possible dose for this patient. It's much easier than just guessing the dose of gonadotropins for a patient. More than 400 women have been treated so far. The mean dose of Follitropin delta in our patients was 10.9 micrograms, which is comparable to slightly below 150 units, international units of FSH. The mean number of oocytes was 11.2, which is spot in the middle of the target oocyte yield of between 8 and 14 eggs. The ongoing pregnancy rate per started cycle was 38.5% in our patient population. So the algorithm allows us to have a good efficiency and also to mitigate OHSS, especially in predicted hyper responders. Let's give an example. Now I'm going to show you the stimulation profile in a woman of age 26 with body weight of 80 kilos, a BMI of 28. She has cycle length of more than 35 days, which is related to the AMH level, which is slightly elevated, 3.95 micrograms per liter, antral follicle count of 20. The patient has been trying to get pregnant with her husband for 2 years, and the cause of infertility was defined as, ovulatory disturbance was defined as a cause of infertility. After 6 cycles of ovulation induction without pregnancy, it was decided that she would go for IVF. And we used Recovel, and the calculated daily dose based on the AMH and the body weight was 9.66 micrograms. So here you see that we did a blood test on day 2 of the menstrual cycle to check the baseline hormone levels, and they were all good. And then we started stimulation. And we give fixed antagonist, GnRH antagonist protocols. We found that the criteria to trigger ovulation with HCG were achieved after 10 days of Follitropin delta stimulation. 11 oocytes were retrieved, and the patient had a single embryo transfer on day 5 after in vitro fertilization. However, she was not pregnant after a fresh embryo transfer. Fortunately, there was a frozen blastocyst as well. And here you can see the protocol for frozen embryo transfer. It's a artificial cycle protocol where we give estradiol valerate by mouth for 2 weeks. Then we do an ultrasound scan. And if we see that the endometrium thickness is at least 6.5 millimeters, we start vaginal micronized progesterone, and a blastocyst transfer is performed on day 6 of vaginal progesterone. We also perform a blood test for progesterone on the day of transfer in order to eventually adjust or increase progesterone by using additional oral dydrogesterone if the progesterone level is too low. But in this case, it wasn't too low, and the patient had an ongoing pregnancy after frozen embryo transfer. Another example regards a patient aged 37, so slightly advanced age, with a body weight of 55 kilos, normal body weight, normal body mass index 18.8 body mass index, normal menstrual cycle of 28 days, an AMH of 3.8, normal antral follicle count. Here, the cause of infertility was a male factor, poor sperm quality, and the patient was administered 6.66 micrograms of Recovel. And here you see how it went. So she had Recovel in a fixed antagonist protocol, HCG trigger. 10 oocytes were retrieved, of which 9 were mature, 7 were fertilized. The patient had a fresh blastocyst transfer, after which she was unfortunately not pregnant. She also had 1 blastocyst frozen by vitrification, was not pregnant after the blastocyst transfer. Then we had a discussion with the patient, 37-year-old patient, 10 oocytes, which was not bad, but we decided in agreement with the patient to increase the Recovel dose in the 2nd cycle. In view of her age, we wanted to have more embryos available for transfer. So we increased the dose to 8 micrograms of Recovel, still a monotherapy, only Recovel, nothing else, in a fixed antagonist protocol. HCG trigger, 17 oocytes after an increased dose, of which 14 were mature. And here we had a fresh blastocyst transfer. She got pregnant with this after this transfer. Unfortunately, it was an early pregnancy loss, but she had 3 more blastocysts cryopreserved by vitrification. And well, we will see what's going to happen with this patient. But just to illustrate that increasing the dose of Recovel can increase the number of oocytes without increasing the risk of OHSS substantially. So this is also a good approach where you can, based on the 1st cycle, adjust the dose and still remain in the very reasonable ovarian response category. Now, just as a last note, I would like to highlight the possibility to combine gonadotropins, and this is a study from Canada where Recovel and Menopur were combined. It's called the MARCS study, where the addition of a number of units of HPHMG were based on the body weight and the Follitropin delta dosage in the patient. And this protocol, according to the authors, would offer the best balance between safety and efficiency in women above 35 years. So in this age category, these authors found that the number of oocytes was still within the target, between 10 and 12 oocytes, and they had an average number of good blastocysts of 5.4 blastocysts, which is a good number. And this resulted in excellent clinical results. In Europe, well, in our center at least, we are not very familiar with the combination of different gonadotropins. So this really depends on the region, but this is definitely an option. Now, just this one to illustrate that the patient got pregnant in the end after a frozen blastocyst transfer, and this is an ongoing pregnancy, after Bricovel in the first fresh cycle. Now, I would like to thank you for watching and listening.